So great. So I'll get us started with one really sort of quick practical question, and then I will open it up to folks in the audience for your questions, and we look forward to hearing what individuals might have to say or queries you have for our speakers. If each of you could just take a moment and sort of think about or respond to or react, and I think we just heard a little bit of this. So how do we take these data innovations, new data sets, new approaches to data analytics, and I should probably come around there, I will, how do we take those and actually translate that into action in cities? You guys have obviously learned a lot and understand very, very intimately the details of your research and some of the limitations of data. How do we take these findings from your perspective and translate that to big cities as we think about reimagining what health looks like in urban cities?
I'm happy to try and start and
answer.
answer
Sure.
a very important question. So in the space of microbiome, from my perspective, I don't think we should be doing much of anything with the justification of microbiome-oriented interventions. I think the science is far too young to justify it, and what we really need is better data collection. So in the literature, and as I was saying at the conclusion of my talk, I think that's something we really have to do is just start taking measurements. And city health departments could be really helpful in that. Funding institutes, foundations, NIH, and providing the infrastructure to monitor before and after urban restoration projects to see if it actually has a meaningful impact on microbiome. So I'm always a big believer in a lot of data before we move strongly into interventions.
Great question. I think that there's a couple of things we can be doing. I think more data is essential. Better, finer spatial scales, better temporal resolution. I think for some of the work I'm interested in terms of climate adaptation, I think moving to in some of the work I showed some of these associations where we see maybe green space being protective. So now planting more trees to try to help with the urban heat island and protect people during heat waves. I really think we want to start testing these adaptation interventions and really looking and seeing if these are actually protecting people during these types of events. The other thing I think we can do is, in some of the work I was showing that's in progress, really linking some of these things more to the healthcare costs that are associated with them. I think to make the case that a lot of these healthcare costs that are not actually captured in the, for example, severe weather damage estimates actually are real costs that our society bears and should be thought about when we're thinking about, justifying some sort of community resilience measure or intervention.
I was thinking about my Google Street View predictors. And in my mind, I think once you kind of go through many different studies and you see how robust this association is, at what levels, and we're finding that crosswalk is pretty, and you also might want to start from the least expensive to the most expensive and look at the bang for your buck, and also look at what outcomes you may impact depending on the structural amenities or feature that you're going after. So we think crosswalk is relatively inexpensive. Other indicators like visible wires seem to be, that's a relatively new one that we're looking at, but that seems to be associated with adverse outcomes, but that would entail bearing wires, and that's pretty expensive. The indicator not single family home, that's more indicating mixed land use, but I think we're already moving towards that where we have communities that are becoming more vertical and more dense. But that's associated generally across the U.S. with better health outcomes. So I would say maybe rank order, the costs, maybe go for the easy and also the one that seems to have bigger impact. And also that might vary depending on the community burden and of the health outcomes that are currently present in that community. So and then also look at how robust that feature is for predicting health outcomes. And we kind of need studies that are wider and bigger to kind of answer that question, because a lot of studies are localized, but at the same time, a lot of action is localized. So it depends on what your action plan is at national or the local level.
I think the only thing I would add to that are well, two things. One is that from our work, I think the key takeaway is that the same intervention is not likely to have the same benefit in all places, depending upon the other pre-existing characteristics of that community. So maybe there is some utility and efficacy to thinking about cost-effectively targeting interventions to those places where they can have the most benefit. The other thing I might sort of caution us about is thinking about the difference between the indicator that works in our epidemiology and in our research versus the real causal factor, and make sure that we're really getting to the right causal factor before we sort of design our interventions, because it would be awfully easy to be kind of misled in how we're shaping or how we're designing interventions when, for example, if we think about, well, Dr. DiCarlo gave us a great example this morning about thinking about the difference between airborne fine particles versus really getting into the sources and the specific chemical characterization of those fine particles so that we make sure we're getting the right sources, the right portion of that pollution that might be having a health benefit or a health impact. In the case of, say, poverty in communities or many of the other socioeconomic indices that we are looking at, we really kind of want to dig in and make sure that we're getting to the right drivers, because there are so many other components that are part of that, to make sure that we're being as meaningfully targeted as possible in thinking about interventions.
Yeah, and I think this was kind of seen through, like, at several presentations where, especially place-based variables, there's a lot of spatial autocorrelation, and a lot of advantage is basically concentrated and a lot of disadvantage is concentrated. So when you're trying to like isolate features, you're going to have a very difficult time if you're interested in place-based effects, and that makes it difficult to tease apart, is this causal? And then you might have to do mini intervention studies to see, okay, if I insert this green space, if I insert this crosswalk, would that change it for this community? But yeah, with the place-based characteristics, we're going to face a lot of, just because of segregation and the way people are distributed across the U.S., they're very difficult to have scientific evidence for that.
David Berrigan, NCI, great panel. And so there's been kind of a critique in geography and social epidemiologists about use of administrative units for these sorts of place-based analyses, and an emphasis on figuring out what the appropriate geographic context is, or the exposure space, or what have you. So could you comment a little on how important it is to go in that direction, or are you satisfied with your spatial units, et cetera?
Can I add a part B to the question? Is also sort of how do you manage that in a land of sort of very disparate data sets that have different boundaries, which I think we talked a little bit about, but how do you sort of balance the two?
I'm actually really glad you asked that question, because I meant to mention that. So I mentioned there were 3 different things that we did to validate stressor indicators in New York. One was a set of focus groups, one was a set of surveys. The third thing that we did that I didn't talk about was we actually created an online platform that we could send out to people who did our survey online that allowed them to draw for us the place that they call their neighborhood. And then we, as possible, could re-aggregate administrative data to it within certain error tolerance parameters. Because you're right that a police precinct or a school district or a census tract is not anything that most people would recognize as their neighborhood. So if you want to get to places that are meaningful and the space that people are really talking about, then yeah, we need other methods to do that. So great question.
I have a question for Ryan Demmer, which is, well, if there is a connection between this biome, microbiome, metabolic conditions like glucose metabolism and diabetes. Well, diabetes is becoming an epidemic, or is an epidemic now in many countries of the world, and how that can be connected with the increased use and abuse of antibiotics.
It's an excellent question. I had a slide, but I knew I was going to run short on time and removed it. Antibiotics, if we think about what shapes the microbiome, antibiotics are let me rephrase that. If we think about what can impact the microbiome, antibiotics are very important, especially for the gut microbiome, not necessarily in all anatomical sites, but it's generally very short-lived. Within 2 to 4 weeks, people tend to go back to where they were at if you look at people pre and post antibiotics and most of the smaller studies that have been done. So overuse and abuse, it's so difficult to look at because it's so prevalent, and it's hard to know what your control group would be. So I'm sure that it's had some influence in shifting things over time, but in terms of dramatic shifts, it seems that for the typical person who maybe has a half a dozen courses of antibiotics and, through their childhood, for example, it's probably not shifting the needle or changing things dramatically in terms of lifetime accumulated risk for cardiometabolic disease. I would probably put my money on things more like diet. That's the other big area of microbiome research where there's a belief that the type of diet you're eating can profoundly influence things. Although having said that, some of the early data coming out from actual large human population-based studies seem to show that the role of dietary patterns is very modest at best. Really focused studies on particular nutrients can be really important for a short period of time, but nobody adheres to those things. So I think it's a great question, but difficult to study in a society where antibiotics are so prevalent. In fact, the slide I was going to show is a New York Times article about in New York City. When I first moved there, I was living in Washington Heights for several years, and I was shocked when I learned that I could go to the local bodega and get, a dose of antibiotics if I needed to do it. Not legally, but that was the practice for many people in the neighborhood, because I was trying to think about what the role of urban environments and policy might be in controlling antibiotic overuse. And I think at the end of the day, at least at the level of municipalities, I'm not sure how much influence they can have on antibiotics.
There you are.
So my question is for Dr. Nguyen. So in light, a couple of the other talks talk about differential effects on vulnerable populations, and I'm wondering if you have a look at differential accuracy of the algorithms and classifiers on low SES areas or minority areas, etc.
Yes, I think we need to delve more deeply into that. We looked at, in the pilot study, we looked at accuracy by city. We were working with 3 cities, Salt Lake, Chicago, and Charleston. And initially, when we were only using Chicago data, the accuracy was much lower for Charleston images. And that's where we added training data from Charleston to increase it to basically the same level as for an urban area. So with the indicators that we have, you can increase accuracy by just getting more specific, like the training data from that particular location. We haven't really, for the US, we kind of just measured accuracy across a mixture, random sample of US images. So we didn't particularly look at the accuracy in urban or rural, but that's something that we should do. And also we should look at the effects by rural or urban status. But I would say like one major thing in the data itself is that rural areas data are not updated as frequently as urban area. And because we labeled a lot of images, and the Charleston images, they are lower quality. A lot of them were kind of fuzzy, and it looked like the camera, so it looked like the quality of the images and also the frequency of the image update is lower in rural areas. So that would be an inherent bias. But depending on the features that you can grab, that might be okay. But if you're getting really fine grained, then you might face that differential bias more.
Yes, sir.
Hi, thank you very much for the presentations. I also have a question regarding Google Street View. One of the advantages of using Google Street View is that you can look at different images in the same point through different moments in time, because you can look through 2007 until now, where there's availability of images. Is your model able to look at the same spot at different moments in time? Because we've been looking through that, and the Google API only is available for the most recent image, but is your model able to look at different moments in time?
Yeah, so when I was talking to now because Google Street View sells images, and so we have to work with the vendor, I asked whether longitudinal historical images are available, and currently they are not making them available. They're making it in certain platforms, so you can kind of click through, but then in terms of like where you go to download the images, they don't have that feature available yet. I feel like the research community can push them a little bit more. But when I was interacting with the vendor, the majority of the business is for marketing and commercial purposes. So they're really weirded out by conversations that we have. They're like, why, like those questions don't really appear to them, and they actually have a clause where they're like, can you only use the most recent image and like just within 30 days, because they're worried that people are making actions based upon old data and that Google's going to be like liable for it. So they actually are like emphasizing that you don't look at historical data, but that's really kind of goes against lots of our interest in looking at longitudinal trends. So it's I think more representation and more interest, they'll get like more used to these questions in the offering. And there's also like they're weirded out that we want to download the data because that violates terms of use if you read through the terms of use, but then you just have to emphasize it's for non-commercial purposes. So these are just some lessons that we learned from like interacting with them.
So this was a really interesting panel, and I just want to go back to the question about the spatial scale very quickly, because it strikes me that one of the interesting things about this panel is that you're all talking about data collection within the context of understanding different mechanisms through which neighborhoods impact health. And it strikes me that in particular, the spatial scale at which you define a neighborhood might vary across these different mechanisms, right? So you might have a different sort of size of neighborhood or a different size of exposure for something like air pollution and health versus the microbiome and health. And given your sort of disparate interests and expertise, I was just wondering, are there any sort of like principles that you use to define the spatial scale of your exposures? You know, I think that would be really informative for us that are interested in these topics.
Yeah, so I'm working on an R01 on that right now, so if you have ideas, that'd be great. Yeah, so you're absolutely right. So for example, in air pollution, there are really well-established, well-documented decay curves for different pollutants within, a couple hundred meters of a major road, whereas in contrast, when we're looking at violence exposures, we don't know how differently people may be impacted in terms of stress pathways by a violent event that occurs on their block versus 3 blocks down the street versus on the other side of their neighborhood or the next neighborhood over. So there probably is something really important there about perceived both scale, size, and shape of the neighborhood environment and perceived areas of risk, and sort of whether and how people perceive themselves to be exposed to psychosocial stressors, and that may be different from area, space, and where they spend time and how they're exposed to physical stressors. And then some of the other exposures, of course, that were discussed probably operate on very different spatial scales, depending on the pathways of interest.
I was just going to say, I think, sometimes there's limitations of the data and then trying to aggregate across different data sources. So in some of my work, I'm looking at both census tract and county. Census tract, at that smaller level, we might expect the health differences to health outcomes to kind of vary more at that smaller level. But, in thinking about preparedness and where those actions might be able to be changed upon, sometimes like in county health departments or preparedness can be, action can be taken at that level. So that's, reason for looking at that level.
In the microbiome area, there's not a lot of spatial scale in the literature. Usually it would be natural ecologists might look at spatial scale in terms of how things change along a mountainside on the north side versus the south side of an exposure, for example. In cities, what I think might be even more interesting than sort of the spatial scale, although there are definite applications and things to be learned there, might just be sort of modes of daily activity. So there was a paper several years ago, some of you might have seen, where a colleague had looked at the microbiome of the New York City subway system, totally inspired by the fact that his daughter licked the hand railing one day, and he said, "Don't do that." And she said, "Well, why not, Daddy? What's there?" So he studied the microbiome of the New York City subway system. But found actually a lot of differences as you went throughout the city. And those variations might be more relevant kind of on a citywide scale than maybe within the neighborhood, or if you're 10 feet high in a tree or 3 feet.
Yes, sir.
Hi. I've been thinking about the last two questions in light of Philadelphia. So my question is actually to you, the moderator. In Philadelphia, the spatial units have been these neighborhoods for probably over 40, maybe 50 years. And my question is, are they still workable? Are they still relevant as a spatial unit for data analysis here in Philadelphia?
Yeah, that's a great question. Recently, maybe about a month ago, maybe, we released a report called Close to Home, which is a project we worked on in collaboration with some folks here at the Urban Health Collaborative to try to do a better job of creating geographic boundaries in Philadelphia around neighborhoods that are much more sort of socially meaningful to people. I would dare not say we did this perfectly. The neighborhood boundaries we created, because of the limitation of the data that we had, were still very, very large. And while the labels for the neighborhoods are much more meaningful to people, whether or not those boundaries actually connect to people and the neighborhood or the environment that actually impacts people's either propensity to be healthier or not is still in question. But I think any urban setting, any city, as all cities are going through sort of shifting demographics, shifting structures, sort of creating more effective ways to monitor those shifts is critically important as we think about neighborhood boundaries, because relying on administrative boundaries, I think we're getting to a point where that's no longer feasible in many ways, particularly things like zip code and census tract, as those shifts happen very, very quickly. And in some ways, we don't even have data to even track those shifts, right? When gentrification's happening in an area, that can happen very quickly in some spaces, and sometimes data lags quickly way behind to be able to detect those types of shifts. So I think your question is perfect in that we have to think about how do we create geographic boundaries, how do we define neighborhoods in a way that's meaningful to people. I'm very fascinated by this notion of asking people what they believe their neighborhood to be, right? We have not done something like that on a large scale in Philly, but doing that kind of exercise in urban settings, I think will provide really, really interesting insights for us, both in public service as well as researchers, around where those boundaries lie. And so when we try to actually look for what impacts neighborhood effects or neighborhood structures would have on a person, we actually are looking at real associations to real people.
Yeah, I kind of have maybe some follow-up comments about that. It's like that question also requires a lot of data, because some initiatives like so to kind of get a boundary that might be meaningful to people based upon the weird neighborhood boundary that they draw themselves, we require point data, right? So point data where you're like that tree, that mailbox, that store, but we don't have that. That data is very expensive. So you're asking for data that's super fine, super real time, and super basically point based upon like, oh, this robbery occurred here, this air pollution measure was here, this tree or sidewalk feature is here. So that is very expensive. That's the only way to produce that kind of specialized data. So it's like, once we get at the consensus that maybe personalized neighborhood boundaries are required, but then the data has to be there to support that kind of initiative. What we're finding because I use both Twitter data and also Google Street View data for ecological studies, the indicators were consistent across boundaries. So that was something that we didn't know would happen, but beneficial features at the ecological correlated well against at the zip code, census tract, county, and state. But then, so that's the different from individual level studies, right? Individual level studies are looking at individual level outcomes, and the predictor is zip code predictor or county predictor. And those we generally pick census tract or zip code because we think that people are going to be walking or interacting more locally potentially, and they have bigger impacts. We did do a study looking at racial climate. So there we had individual birth outcomes, and the predictor was county level racial climate measured by tweets, and also we tried it with state level racial climate measured by tweets, and actually the state level characteristics were more predictive, but maybe because there are more state level policies that are going to be determined with racial implications. But there, even a large aggregation still saw like a impact potentially on individual level birth outcomes. So it depends on like the feature that you're looking at, but it's no small task to get that kind of data to make individualized boundaries.
Yeah, and I guess the other thing, sort of from a reporting and research perspective, the boundaries are important, but I think on the practical side, we just have to recognize that boundaries are almost artificial, right? I mean, people live in neighborhoods, but in fact, those boundaries move so quickly and can move very quickly and don't actually mean anything. I'm not confined to my neighborhood. I have to go to other neighborhoods for other things. So thinking practically, we have to think about sort of the source of things contributing to good and bad health and get to the source and not think about the boundary. I think is really sort of, if we want to move the needle of urban health and move the needle of like health in neighborhoods and cities, and really think about it through an equity lens, we don't focus on the boundary and focus on the issue and address the issue, and then hopefully the boundaries will start to blur because health will become more equitable across the boundaries. Other questions? We have about 2 more minutes. Well, I'll ask one closing question, I guess, for you guys. As you think about sort of the future of analytics and the world is sort of really, the world of data analytics is moving ahead and everyone's starting to sort of think about big data. What do you see sort of as a next step for us in urban health and epidemiology and the work that you've done specifically, sort of like where do you want to go in terms of, or what do you see as sort of the next big thing in terms of what we should be advocating for as epidemiologists in terms of data analytics, in terms of data resources that would might help inform this conversation around the impact of environment and physical structures on health?
Well, I'll offer a thought on that, and maybe it's by way of being provocative, but I think oftentimes, I won't speak for all the epidemiologists in the room, but only myself. But I think we might have a tendency to kind of get carried away with the method sometimes and forget to stop and back up and think about what our data really can and can't tell us and what it really may be proxying for, and making sure that we're spending as much time developing our theory and really understanding what our data means, and the underlying trends and factors went into the original collection of that data, because oftentimes with big data approaches, we didn't design that data set. We didn't collect it for our purposes. So there are embedded assumptions already within it, and making sure that we're very careful and cautious and clear when we're using big data approaches, that we understand what those are and what the data may and may not be able to tell us.
For me, moving forward, one of the big challenges is that when you're doing new data collection mechanisms, they're often very expensive. So microbiome is very expensive if you want to do the latest and greatest. In fact, I've submitted grants where by the time it got reviewed, study section said, this machine is going out of service, something as technical as that. Obviously, we'll get the new machine, but you have to go through another grant cycle just to say, okay, now we'll use the next generation of this particular method. So to stay on the cutting edge, you have to spend a lot of money, and it precludes your ability to get really good data on other really important factors. So I would love to have more place-based information about, GPS type measures, air pollution measures that would be informative as potential confounding or interacting variables with the microbiome that I'm primarily interested in. But it's totally impractical to add that in any study that you do in most settings. So I'd love to see things move in a direction where there's more data collection that's openly available to researchers to integrate into the more refined questions that they're trying to ask.
I think I'll piggyback on that response. I do see the data integration and that data is for neighborhood and place-based effects are more prevalent now. For instance, Miriam, 500 cities, and so those data are relatively new. Like the wave of getting place-based data across many different locations and county health rankings. So now we're seeing more open data sources and people doing larger neighborhood studies, and that was kind of unique to previous, rounds of research where you focus just on like one city. So and then open data and sharing data, I feel like that's more like moving now and being pushed and advocated for it within public health. Because other disciplines are already, like computer science, those are already, they share their code and share their data. The public health is kind of moving in that direction as well.
I will just echo that, only because in the context of things like disasters, we're often responding to an event, and so we're really stuck with administrative data if we want to say anything about the historical situation. And so, open data and sharing of data would really help within that context as well.
Great. Well, thank you all. I think we have a couple of housekeeping things we need to cover, and then everyone will be on to the next thing. Thank you.
So I'm Gina Lavasi. I'm the Dornsife Associate Professor of Urban Health here at Drexel, and really thrilled to have been part of this exciting day. I hope that our panels that we've had so far have sparked empathy and ideas and helped you question your assumptions, given all the complexity of what we've seen presented, and even been weirded out by perspectives and methods that are different from what you're used to. So I wanted to just ask you to join me in thanking all the day's speakers for their great presentations. A lot of work has gone into this day.